This morning I'm talking about some interventions that we think may be useful for primary health care based on a number of research studies that we've been conducting over a long time now in Aboriginal and Torres Strait Islander health. I might also put a call out. I've been to Cairns so many times, but I've never been to the Torres Strait. So all you Torres Strait Islander mob here, I'd love an invitation to come up to the Torres and experience the Torres. You know, I'm from Central Australia. I'm a Pinyara Narunga fella, and I've never been to the Torres Strait Islands. So all of you mob, take that message stick back home to the Torres and make sure I get an invitation up there, because I hear that it is gorgeous up there. So what I'm going to talk about this morning is a whole range of research studies that we've been undertaking, and really is trying to shape some evidence about these long-standing rates of STIs that have been present in many Aboriginal communities. I'm going to talk about access, what we know about access to health services for our young people, what kind of testing rates have been we've found across a range of research studies, what positivity and prevalence data we have from a range of different sources, and where do we go to from here. So I've been conducting research for about the last 10 years. I've worked in the area of STIs for 20 years, but I've been conducting research in academic world for the last 10 years. And so been really conducting some research around health services research, population kind of health studies, national cross-sectional surveys. We're really trialling some point-of-care machines for STIs in a number of communities, and really some epidemiological studies. So really this combined evidence now is really starting to tell us where we should shape our interventions to kind of get some runs on the board in this area that we haven't managed to get runs on the board for. Many of you will know that we've made some significant gains in Aboriginal and Torres Strait Islander health over the last 30 years, particularly in the areas of child and maternal health, and we're starting to get really good outcomes in chronic disease management now. There seems to me they seem to be much more difficult areas to kind of get on top of, but this area of STIs, which are easily tested, easily treated for, we don't seem to have made many gains over the last 20 years. So I'm going to try and unpack that and then try and find some solutions for you, for all of you working in primary care. So I guess the thing for STIs and for our population is that I'm probably not telling you anything new here, but STIs predominantly affect young people, and for our population we have a very young age distribution compared to non-Aboriginal people. So about 50% of our population are under the age of 25, compared to about 32% in the non-Aboriginal population. And importantly, our population is expected to grow by about 40% over the next 15 years or so. So really some major issues around STIs about young people and why there's a need to get on top of STIs over the next little while. This is a slide from the MGA that was published in 2013 by Peter Azzopardi about leading incident conditions affecting Indigenous people aged 10 to 24 years of age. And you can see there that chlamydia and gonorrhea lead the field by a very long way. So in terms of incident conditions affecting this adolescent age group 10 to 24 is 3,400 per 100,000, a rate of 3,400, and gonorrhea about 1,800 in our young population. And compared to all the other kind of adolescent type issues that are impacting on our population, so really it really is quite an issue. And I'll just show some quick slides from national epidemiological the surveillance data that's collected. This burden of infection really escalates by remoteness, so really quite important for PHN like the North Queensland one. So there were rates of chlamydia, but even in the city you can see rates of infection among Aboriginal people in the cities are about double that of non-Aboriginal population. For gonorrhea, you won't find gonorrhea rarely in young heterosexual people. These little blips in the line here are really for non-Aboriginal people are among MSM. And so the really quite discrepant rates of gonorrhea in our population, and particularly it really escalates as you go further remote. And so the reasons why they think remote health services or remote communities, I think there's this burden of infection in these communities. Access to healthcare services is less. We've got a very young mobile population in these communities. and we haven't been able to get on top of it. So really quite prevalent rates of STIs in these communities. So what I'm going to talk about now is some data that's been generated from a number of research studies about access to health services. What do we know about young people who access health services? So this is a study from New South Wales. It's from Regional Aboriginal Medical Services in New South Wales. And what we can see here is a pattern, which will appear over the next few slides, is that females attend health services much more than males. So this is a cohort of around 2,600 people who attended these regional Aboriginal medical services. They're aged 16 to 29, and we looked at that cohort to see how often out of this cohort they were attending health services. So for young females, about a third of them came every year out of the 3 years, another third in 2 out of the 3 years, and 40% of them once out of the 3 years. So still, even for 16 to 29-year-olds, there's a fair whack of females who only come once out of the 3 years to that primary healthcare service in those regional towns. But for males, you can see less than 20% came to the clinics every year out of the 3 years, and about a third 2 out of the 3 years, and importantly, over half of them, just over half of them, only came once out of the 3 years. And if you think about clinical guidelines for STIs, they say recommend testing for every person in the age group 16 to 29 once a year. So there's a fair whack of our population who are not accessing those health services, who don't have that opportunity to get on top of that. So we really need to encourage greater access to health services. This is another slide from another study in New South Wales. Again, really just important to show there's a significant gap in access to health services between young men and young women. So this is from an Aboriginal Sexual and Reproductive Health Program in New South Wales. You can see these are not every year out of the 3 years, but this is every year, 10 to 13. Young men attended clinics 3 times a year, compared to around 5 to 6, 7 times for young females. So about double, half the rate of access to compared to young women in this study. We went to far north Queensland. This is data done from the STRIVE study, a large randomised trial we conducted over 5 years. This is about access. So this is a bit different because this data includes the incentives that Trish Fagan, many of you probably know here, ran incentives to get STI checks done among the young population in far north Queensland. So this is really remote community in the Cape. And you can see, again, a similar pattern, but not as marked, but in this age group here, probably 25 to 29, a very big difference between females access. So about 100% of young females in the 25 to 29-year-old age group in the Cape access the health service at least once a year in those Cape communities. But this is done in the context of incentives, so phone cards being offered for STI checks in there. So if we took out that period in this study, it'd be back down to a little bit higher, but very big gaps in kind of service delivery without that incentive being provided. So what do we know, just in summary, of access to health services? We know that men are accessing clinics much less than females. They do so about a third less than women. And they're often presenting with symptoms. So we've got some data from our large randomised trial in 65 remote communities that really kind of show that men are accessing the clinics much more when they have symptoms compared to asymptomatic screening periods. And attendance increases with age. So across the age group 16 to 29, attendance increases. So what do we know about testing outcomes? So I might just turn to the clinical guidelines, which really most of them say recommend annual testing of 15 to 29. They vary a little bit in age. Most of them recommend testing for chlamydia, and most other guidelines say in endemic areas you need to test for those infections that are prevalent. So you need to understand your epidemiology in your area and then offer testing for those STIs. So in remote areas, people would be routinely testing for chlamydia, gonorrhea, trichomonas and syphilis. So the guidelines are there. They also say you need to test for reinfection, and if you do diagnose chlamydia or gonorrhea, you need to offer a full STI screen, including HIV. So I just want to go through some of this indicator data that we have generated over the last few years. So this is from the STRIVE study. I'll keep on mentioning these studies, but this is from the STRIVE study. It shows a couple of things. So this is a randomised trial in 65 remote communities, including some Cape York communities. So I think there are 3 communities in Cape York that were involved in the study. Most were in the Northern Territory and 8 in the Kimberley region. So what we did was implemented a comprehensive CQI program into each of these communities. It was a step wedge design, so kind of I could see the differences between the control groups who had the intervention versus those who hadn't. And we tried to increase our testing rates in these communities over the 4-year period. And this is led by a large group of people, but predominantly at the Kirby Institute in Sydney, but I was the Chief of Operations of this study. And what we did do was manage to increase the number of tests over the 65 remote communities by about 40% in these remote communities. But what we didn't impact was prevalence. And the primary outcome of this trial was to increase testing rates to have an impact on the reduction in prevalence of common STIs like chlamydia, gonorrhea and trichomonas for the 3. And our age group was 15 to 34 in this study. So we increased testing for the 3 STIs by 40%, and you can see there's a large number of tests that are done each year, so around 13 or 14,000. There's lots of STI testing happening, but one thing we didn't see, which was our primary outcome, we saw only minor impacts so this is testing coverage. So even though we had this comprehensive CQI program in there, you can see for females here, we only ever reached a testing coverage of around 40, just over 40% in these remote communities. So we had STRIVE coordinators based in the regions. They were working with the health services. They were implementing CQI. We were generating reports. We were feeding those back every 6 months. There was follow-up phone calls in between. There was a huge amount of work that went into this study to try and improve these testing rates. But still, of all the women that came into the clinic, only about 40% of them were tested. And it didn't matter by intervention year. So this blue line here had the intervention of CQI for 3 years. This one had it for 2 years, so it kind of increased. And the one that came in later, probably the effects of STRIVE being around for a little while, had and you can see the placebo effect of improved testing with the ones that didn't actually have the CQI. So there was some improvements in coverage, but not quite enough to what the guidelines say, which is 100% of testing. And for males, similarly, males attend less in the clinic, but even they are offered testing less when they are in the clinic. So around 30% of males were offered testing, even in this really kind of comprehensive CQI support that was provided to remote clinics during the period. So the answers are not easy, is what I'm saying. The answers are not easy to bring these issues under control. So I also want to show some testing rates from other services from across Australia. So this is a study that was published in 2012. It's chlamydia testing. Of course, you'd expect sexual health services to be testing for chlamydia because that's what their primary role is, to be STI, bloodborne virus service providers. Family planning, sexual and reproductive health issues, so quite a little bit less of chlamydia testing of all people that came to the clinic. These are Aboriginal people who came to the clinic. Aboriginal medical services, so these are people who came to, Aboriginal medical services, they're not primary sexual health. About 20% of young people that came to the clinics were tested for STIs, and private general practice around 5 or 6% for chlamydia testing. So this really shows the kind of people who are in the right age group who are coming into clinics who are being offered STI testing, the proportion who are offered STI testing. So we've got some way to go in terms of improving outcomes both in the ACCHS sector and in the general practice sector. This is a study from New South Wales, regional communities, and so this is also a study that tried to implement CQI in these communities. This green shaded area here is the period where the CQI program was implemented. There's a smaller number of communities, four communities, and you can see starting from a very low base of for females of around 5 to 8%, we can see it kind of moved up to close to 30% testing after the CQI period was implemented. So there is really some value in implementing CQI programs, but I don't think my thinking is that it's not enough as a standalone intervention for primary care. And similarly for males, even a lower starting baseline starting for testing, but still a lower outcome of testing, around 25% ending up being tested, even in a CQI environment. So there are plenty of opportunities for offering testing for young people when they come to clinics, and so this is also from the same study from SHIMA, it's called. One thing about research is they love to make a study name. It's a really important part of research to make a study name. So this is SHIMA, which kind of means something around sexual health improvement. I don't know what the MMMER is, but it's kind of like, there's a name for it. And so we looked at the SHIMA data, and it was a clinical audit conducted by Dr. Janet Knox, and she looked at all the general, so records from medical services in females, and looked at where the opportunities were for offering STI testing and where they were missed. And so she classified them into general medical reproductive health and STI symptom checks, and where the STI check was offered. And so you can see a very small proportion of general medical consultations were offered an STI check. Females who are presenting for reproductive health, very large gap in offering STI testing at an ideal opportunity, you would think. And in adult health checks, about 50% of them were offered STI checks. So one thing about the adult health check, the 715, is it's not mandatory to conduct the STI check, but I think it should be. So a lot of 715s really, was implemented for chronic disease management, and really it's not mandatory for people to offer it. They can do it without offering the STI check. So I think it absolutely needs to be mandatory. The STI checks, the adult health checks, are really for 15 to 54 or 15 over. Probably we don't need to be testing 45-year-olds or 50-year-olds for STIs, but 15 to 29-year-olds who have a 715 should definitely be offered STI checks in those settings. And this is a similar slide for men in terms of the context of where they are offered testing or not offered testing for STIs. So you can see there's some big gaps and some great opportunities to offer STI testing that are not being conducted in our health services. So where are the gaps? So I really think that there's some major gaps between the guidelines which say 100% of young people should be offered testing, but what it turns out across a range of different studies is between 5 and 40% are offered testing when they're accessing our health services. So there's a really big gap there to fill, and I think if we can start to fill these gaps, we can probably get some runs on the board in this area of STIs. So testing for reinfection is recommended around 3 months. That ranges from 20 to 40%. I didn't show that data, but it really ranges of 20 to 40% of people who are tested for reinfection at 3 months. And I think the context of testing, if we can really make sure that we get the right age group tested within a 715, that'd be a great start. If you can get young females who are presenting for emergency contraception, pregnancy, reproductive health issues, get tested for STIs at the same time, it's an ideal opportunity. We might be able to start to fill some of these gaps. So this is the bad news part of the presentation. I think if they haven't been bad enough, but this is the bad news part of the presentation. So this is really about what do we know about the burden of infection across a range of different settings for STIs and bloodborne, for STIs in our population. So this is chlamydia prevalence. I just wanted to show this. This is from Jane Hocking's study called ACCHS, which they're trying to implement a screening program for chlamydia in private general practice across and some Aboriginal medical services across the eastern seaboard. So there's some Queensland sites, lower southeast Queensland, all the way through New South Wales and Victoria, and Jane Hocking's at the University of Melbourne. So she has done a chlamydia prevalence study in about 150 general practice clinics, and this is the prevalence they found overall for chlamydia in the population along the eastern seaboard. So about, in total, a total prevalence of just under 5%, but Indigenous people a higher prevalence, 6%, and for rural communities, just under 5%, so just a little bit higher than the overall population. But just keep that in mind, about 5% prevalence for chlamydia in the predominantly non-Aboriginal population along the eastern seaboard. This is a study, similar kind of analysis, prevalence study of co-infections from our remote communities from the STRIVE study. And so this is a slide of the burden of infection, of co-infection for STIs in young females from the study, and the next slide is males. And what you can really see here is the burden of infection among young Aboriginal people who live in remote areas. So around 40% of young women aged 16 to 24 have either chlamydia and gonorrhea, gonorrhea and chlamydia, chlamydia and trichomonas, or gonorrhea and trichomonas. Really unacceptable. You think about the burden of infection along mainstream general practice along the eastern seaboard, 5% prevalence for chlamydia. You won't find gonorrhea or trichomonas in non-Aboriginal women along the eastern seaboard. You might find a little bit, very less than 1% for both of those infections, but really a significant burden of infection for our young people living in remote communities. Now, young people have rights to healthy sexual and reproductive lives as much as people who live in remote community, as much as any other young Australian in the population. And so this really, when we embarked on STRIVE, no one had ever done a prevalence study in remote Australia. We always knew the notification data was high, but we never knew actually what the prevalence was in our communities. So this is really, for the first time, highlighting the really big job ahead for us to get these rates down. And for young men, Heather and others in the room who are experts in sexual health will understand that trichomonas doesn't really stick around in young men. It kind of gets washed out in the urethra. And so the burden of infection for chlamydia and gonorrhea with trichomonas is much lower in young men. But you can see the burden of infection for a young man, and this is across data generated across 65 remote communities. So for young men living in remote communities, almost 1 in 2 or greater than 1 in 2 have either chlamydia and gonorrhea or gonorrhea and chlamydia in those population, in these communities. So it's no wonder we, if you go back a few slides, we increased testing rates by 40%, but never reduced the community prevalence. So we need to really aim to get the testing rates right up to around 80%, double the efforts where we had in the STRIVE study, to bring down kind of prevalence rates like this. Nowhere else in Australia, nowhere else in the world probably has prevalence rates like this, except for sub-Saharan Africa, in the context of HIV at the same time, probably at similar rates to HIV. So, and I'll talk about HIV in a moment. So trichomonas, many people might not have heard of trichomonas, but it's a STI. It sticks around much longer in women, as I said before. And this is also prevalence data from remote communities, a very high burden of infection. It's associated with poor outcomes in pregnancy. It's implicated in exponentially transmitting HIV if there's trichomonas present when HIV comes into contact with populations. All of these STIs increase the risk of HIV being transmitted if they're present. So really, the big job ahead of us is to get these rates of STIs down before HIV starts to creep into our communities. Because if there's one STI present, particularly an STI like syphilis, which I haven't talked about yet, but I will, if there's one STI present, it increases the risk of HIV being transmitted. If there's 2 or 3 STIs, like I've just shown, it will really go like wildfire in our communities. Again, just to compare data, so this is from Sexual Health Services. It's really only focused on chlamydia. But of course you'd expect a high positivity rate in sexual health clinics. So this is around 20% of young people who come to the clinic who are tested for chlamydia, they test positive for chlamydia. So you'd expect them to kind of be a higher prevalence rate than private general practice. This other study, which is around 5%, because people are coming to a sexual health clinic because they think they might have exposed themselves to an STI. And again, just to compare our remote community data with other populations, overall, a 9% prevalence for chlamydia. No gonorrhea in these communities in New South Wales, and certainly we haven't studied trichomonas in these populations as yet, but it's some work to do in the end. Now let me turn, sorry that's a bit blurred there, this is the thing between Max and PC. We published a paper in 2010 in the MJA, and really, we said to the MJ, the title of the MJ, we submitted to the MJ, said, can there be a good news story in Aboriginal and Torres Strait Islander health? Of course, the MJ said, no, let's do a much more boring title, Epidemiology of Syphilis in Remote can we move towards elimination? So what we were advocating for was let's move towards elimination of infectious syphilis in our communities. And what we did was analysed all the notification data. We'd moved down to 129 notifications across the three major jurisdictions where they have syphilis: the Northern Territory, WA and Queensland. Everyone had done a great job. There's syphilis registers, there's great databases, people were followed up, people were working very hard to get rid of syphilis. And at the same time we published this paper, not very long after that, there was an outbreak in Western Queensland, far northwest Queensland, Doomadgee, and I think it's publicly stated, and Queensland Health didn't respond effectively to get on top of this outbreak. And really this points to a couple of things. Really, what do we do in the future around outbreaks? And what do we do if it's not a syphilis outbreak but a HIV outbreak? Will we allow this to go the way it has gone? And so right now we've got about, so it started around the Mount Isa region, as I said. It went all the way through, so it went from Western Queensland into Borroloola, down to the Barkly region in the Northern Territory, down to Central Australia, up through the west, and now it's in Western Australia. Basically, the syphilis outbreak is across the Northern Australia. It's moved into the Cape, it's moved down to Townsville, and currently we have about 1,000 cases across the three jurisdictions. We did have only 129 cases in 2010. We've also had 10 cases of congenital syphilis, including 3 neonatal stillbirths because of the syphilis outbreak. So really unacceptable, and really there is this major outbreak committee happening now, but unfortunately it started 3 years too late. And so what we're trying to do now is just keep this outbreak under control in the three jurisdictions. Nanny Preston-Thomas, who's sitting in the room here, does great work on that outbreak committee for Queensland, and she inherited this outbreak and does great work. So it just points to, if this had happened in wide Australia, let's be honest about this, CDNA, everyone would have been responding to this outbreak. So it's just gone on to the CDNA, Communicable Disease Network Australia's agenda just recently. So, because they're black people who live in a remote community, let it go, let it go, let it go. And then, we'll be jumping up and down at Queensland Health. It was at the same time that Campbell Newman's government were dismantling public health services, including a lot of sexual health positions across Queensland. So really talks about it's really an epidemiological, political impact on public health, really, and really it's not a good story. And so this is how the syphilis cases have spread across our community. So all of the blue, Queensland, you belong to these, so own them. They're all yours. And really, we haven't managed to get it under control. There's been some kind of good news in the last few months from Queensland here. And these ones are the Northern Territory, and the green ones, you can see how it's spread across. See, it also says something very good about mobility. We know that blackfellas travel. We know that we've got connections interstate. I've talked to lots of Aboriginal people here who say, I've got family in Alice Springs, or I've got family here. We've got mob everywhere. There's no border for us, and this is what happens when you've got high prevalence of an infection, mobility, travels across borders, and not a very good public health outbreak response. There's an excellent public health outbreak response now in that we're moving close to 1,000 cases, but we should have had it right down here when there were like 5 cases. We should have had a really good outbreak response, and then we would have probably moved to elimination of infectious syphilis. So what we're doing about, went backwards there. So we're about to roll out a syphilis education testing campaign to address this. It will really work across zones. You'll be all faced with television commercials around syphilis testing. It'll be targeted towards Aboriginal young people, television commercials, radio, doing online peer activation, implementation of rapid tests for syphilis, trying to get as many young Aboriginal people tested for syphilis, because the predominant age group affected by this outbreak are 15 to 25-year-olds, and predominantly living in remote areas across those 3 jurisdictions. So really high prevalence rates of STIs in communities. I just want to move now to HIV. So there's some very good, evidence to say that the presence of other STIs really can potentiate HIV transmission in populations around the world. So the evidence kind of says between 2 and 5 times fold increased risk if there are other STIs present in a population for HIV to be transmitted. So fortunately, we've had very few cases of notifications of HIV in remote areas across Australia. But that is all changing. So I'm going to talk about Cairns in a moment, but it's all changing, and it's changing very quickly. So we need to get on top of these things very quickly. Unfortunately, there's a double whammy for Aboriginal communities and HIV. So we've got these high rates of STIs and an ever-increasing evidence base about increasing amounts of injecting drug use in our population. So those two things coming together really create a landscape for HIV to escalate rapidly in our population. So those two things together will be what drives our HIV rates. And unfortunately, fortunately, HIV is one of the few good news stories in Aboriginal and Torres Strait Islander health over the last 20 years. So we've had very comparable rates of HIV compared to the non-Aboriginal population. But you can see here over the last 10 years, there's been an increasing number of diagnoses each year for the Aboriginal and Torres Strait Islander population, where the line's a bit more flat in the non-Aboriginal population. So these are the absolute numbers of diagnoses across Australia every year. So it doesn't appear to be very much, but when you compare the age population rate, you can see quite clearly here there's an ever-increasing trend of HIV diverging from non-Aboriginal population rates. So for the first time in 22 years that we've been collecting HIV national notifiable data, there's a clear divergence and a trend of increasing numbers of HIV in our population. So we need to be all on the ball for this one, because you've just seen what happened with the syphilis outbreak. And we've got a very different epidemiological profile compared to non-Aboriginal people. So these are pie charts from the last 5 years, how people say they've acquired HIV. So in the non-Aboriginal population, about 80% of the diagnoses are among gay men. So if the majority of notifications are limited to the gay men, which would make up around 5, maybe 10% of the total population, it kind of stays there. But for our population, 50% of our diagnoses, or just under 50% of our diagnoses, are in the heterosexual population. Once it gets into heterosexual populations, as it has done over the globe, in Africa and Southeast Asia and Eastern Europe, it has a much bigger proportion of the population. So 95% of the population are heterosexual. It has a much higher proportion to escalate. So we've got to keep these rates down in the next little while. So I just want to show some data from Canada, and I particularly want to focus on this province here. Saskatchewan's probably not unlike, the region here, like North Queensland. Actually, it's probably not so about 18% of the population in Saskatchewan are First Nations people, Aboriginal, Metis, Inuits, and overall in Canada, about 4% of the population are Aboriginal, First Peoples. But every year, about 20% of all the HIV diagnoses in Canada are diagnosed among First Nations people. And so Saskatchewan is very similar, I think, to far north Queensland, to be honest. So this is a chart over the last few years of HIV diagnoses in Saskatchewan by risk factor. So you can see here the green line is among men who have sex with men, heterosexual people, the purple line, and this line here is among people who said they had a history of injecting drug use. So this is where I'm going to bring in the injecting drug use combined with the STI stuff. And similarly, if you did it by race, Aboriginal people are this line here. So Aboriginal people who are injecting in Saskatchewan drove the epidemic in Saskatchewan. So 18% of the population in Saskatchewan are people of First Nations origin, very similar to far north Queensland, live in isolated communities, and were mostly injecting prescription drugs, so on reserve, so in communities. So. And if you look at the recent data from the CDC, the Public Health Agency in Canada, a population rate of 5.9 per 100,000 in Canada. In Saskatchewan itself, double that, but on reserve in communities. On reserve is equivalent to remote communities, very high prevalence rate, very high population rate of HIV diagnoses. So if we're not concerned about injecting, we should be concerned about injecting, and it needs to get on everyone's radar, because people living in communities, you'll know that there is injecting happening. There might not be great, but when the issue is when people come down to Cairns, they might start injecting, might inject unsafely and go back home unknowingly with HIV or with hepatitis C. So everyone needs to be on the agenda here. And you combine that with the high rates of STIs and the risks for HIV, really you can see that we're in for some rough times if we don't change the way we do things. So in the Cairns region here, so Darren Russell's kind of given me permission to present this data. Prior to 2014, there's usually 15 cases, around 13, 14, 15 cases of HIV diagnosed in Cairns, and usually 1 or 2 cases of those 15 are among Aboriginal people. Yeah? But over the last year, between 2014 to now, there's been a significant increase in the number of HIV among Aboriginal people diagnosed in the Cairns region. So 10 of the 20 cases, or 50% of the HIV cases in the Cairns, diagnosed in Cairns, are among Aboriginal people, mostly young, mostly male, and most of them report having sex with both males and females. And importantly, the other 10 cases here, this is Cairns Sexual Health Service, these 10 cases were people, they weren't acquired locally. So really important stuff here around treatment as prevention. So these other 10 cases were people who might have flown in from Papua New Guinea, like expats or Papua New Guineans, or people who might have moved here and been diagnosed here. They weren't acquired. The HIV cases weren't acquired in Cairns. So the 10 of the 20 weren't acquired. And Darren and his team really say that these, so there's no new cases in the non-Aboriginal population in Cairns. And what they say is that high rates of testing among the non-Indigenous population, but for those who are diagnosed with HIV, a high proportion of them are on treatment. And if you're on treatment, you can get down to an undetectable viral load and then not transmit HIV. So really a great strategy, but it's working for one population, but obviously not for the other population. And again, a major gap in terms of our equity in terms of this. So really important stuff. So this is a quite complex slide, but I'll just make it simplified for you. This is also data that's about to be published in the MJA. It's from the STRIVE study. And we looked at how our primary healthcare services were going in terms of offering HIV testing after a positive STI diagnosis. So 15,000 cases over a 4-year period in the 65 remote communities. You can see females are diagnosed significantly more than males. Again, reflection of access, but also a reflection of testing in those services. 15,000 cases, a third of them, so these are positive cases, only a third of them were offered testing within 30 days. And syphilis, 44% within 30 days. If you take out the HIV test that was done on the same day, only 26% were done on the same day, and 6% were done within the 30 days. So 100% of all STI tests should be offered within 30 days. Only 6%, excluding the 26 that were done on the same day. So really, if you think globally, 2/3 of all these cases haven't been tested for HIV. If we're going to get on top of HIV in remote, then that's one simple indicator that we absolutely need to fix up. So really important data from us, and we need to get going. George, are you coming to get me off? Yeah, okay. So, all right. I haven't got many to go, yeah. So I like to keep you at bay. Just sit down there, take a seat, yeah. I want you to be comfortable. It is NAIDOC week after all, yeah. So really we need to fix up this, that indicator about HIV. So there's actually a report online around HIV and really... So what are the options? I think, there's lots of options that have been touted to try and bring these rates down. So mass treatment of communities, I think there'll be resistance from communities. That's offering everyone treatment at the same time. I don't think it's a very good option, and the evidence is quite weak around it. The logistics of trying to do that across all remote communities at the same time Do we need to do that in a country like Australia where we've got comprehensive primary care services? So a whole range of options there. Point of care machines, they're great for people who come to the clinic, but those that don't come to the clinic, it's not so good. Screening with regular opportunistic testing, I think that's a very good program from Central Australia there. It's achieved some reductions, but the community need to take ownership of it. WA, interestingly, have increased the frequency of testing in the guidelines. So now they say not only one test a year, twice a year for remote Aboriginal communities. So it'll be interesting, they can't get to 100% in the one test a year, but maybe it will say to clinicians working in these remote communities, okay, we need to test at least twice a year, so maybe we can at least offer testing once a year. So maybe it's really about semantics of language. So this is some work we're about to start with Poonam Hema. It's the Centre of Research Excellence. What we're trying to do is generate new research, translate that research into findings, clinical guidelines, build the capacity of people not working in research institutes, and collaboration. So we're working with 5 different clinical hubs, and one of them is Poonam Hema in Cape York, Iui, New South Wales, South Australia and the Kimberley region. And one project is really to establish a national surveillance network of Aboriginal medical services and other primary care sites working with Aboriginal communities to improve our understanding of STIs and blood-borne viruses and where we need to go to with interventions. We're aiming for around 40 AMSs and other health services to participate. And why? Because we currently rely on notification data, not testing data. We have no testing data, we have no treatment data, we have no accompanying behavioural data, and we need to account for service characteristics in these things. So it'd be a very good network to set up and for us to shape our further evidence around what needs to be done in this area. And I really think this guideline around 100% needs to be looked at, and maybe what we're trying to do with our CRE is to try and generate some behavioural data alongside our clinical data. So one of the guidelines says 16 to 29-year-olds need to be, 100% of them need to be tested. So just from the Goanna study that we conducted, 2,900 young people, the right age group, so 67% of young people aged 16 to 19 years were reported being single, but only 45% at 25 to 29 were single. So you'd assume, 55% probably in mostly stable, single, monogamous relationship. Do those people need to be offered testing annually? So just thinking about our population, because trying to unpack why services are only getting to 40%. So trying to unpack that and try and see if we can make it not look so insurmountable for primary healthcare providers when they're doing these jobs. So I think we really need to start looking at early sexual debut and how we address that in our communities. Core transmitters was actually brought up by very senior eldermen in the Kimberley this week about core transmitters. What happens about the fellow who keeps on getting reinfected? What do we do about those people? Are they the people who are driving these high rates of STIs in communities? So we're really going to try and target some really controversial, sensitive kind of areas over the next 5 years, and really, yeah. George is probably going to get me off, so I might leave it at that. But I think there's plenty to think about there in terms of what you need to do in primary health care over the next little while. So that's the last slide anyway. So thanks very much.